little pipe on that.
Yeah, I was going to say I better check the bottom of my chair.
It's the fire I'm really more worried about. All right, let's keep going. 20 slides away from the end of this one. All right, so oxygen saturation, right? So this is the measurement of proportion of oxygen attached to the hemoglobin. Okay? You're going to write it as SpO2 and then the percentage. Whoops, makes sense? This is what SpO2 looks like. No? There you go. Okay? Some of these are portable, like little tiny ones. McCone, you got yours on you? So some are little bitty tiny ones. Take your time. Okay, I know you can't see this because it's dark, but little tiny ones, right? These are nice because you can like put them on your belt and stuff. I'm a big fan of ones that have strings, right, attached to something that you can't walk off without grabbing this, right? So this one's nice, or there's something along the lines of this, okay, a little bit bigger. Now the nice thing is most of these SpO2s also give you a heart rate, okay? We still recommend you take a manual one, just like for the auscultated blood pressure or the automatic blood pressure, but it gives you a heart rate, okay? Let's see here. This pretty much goes on every single person, right? There's no reason why you shouldn't use this on anybody. Pediatrics, we have stickers that go on their toe, right? Because little babies won't leave this on their fingers, and it's actually a sticker that goes on their big toe and does the exact same thing, only it's stuck, and so they can't pull it off or kick it off or something like that, right? Now, the downfall with this is it has sometimes it can give you inaccurate readings, okay? This is nice in about 99.9% of your patients, okay, for the most part. So here are parameters that we'll talk about when it'll give you false readings. So normal, okay, now I know it says 96 to 100 because that's what your textbook says. Normal is 94 to 96%, okay? This is textbook, real life, right? We're changing those guidelines when we talked about oxygen toxicity, right? 94 to 96, Libby. I don't think I put any with normal, right? We'll talk about hypoxia here in a second. Make sense? So mild hypoxia, I want you to put 91 to 94. Okay? Significant to moderate hypoxia, you can put 86 to 90, and then severe hypoxia, 85% or less. Okay? Normal, 94 to 96. Mild hypoxia, 91 to 94. Significant or moderate hypoxia, 86 to 90. Severe hypoxia, 85% or less. Okay? The reason why, or the thought process behind of changing from nasal cannula to non-rebreather is easy if you look at this slide. If I tell you that you wanted to take, or if I told you all patients belong at 100% oxygen, right? That's your goal, if that's the case, and they were at 92%, what is the fastest way to take them from 92 to 100? What's the fastest way to raise them 8%? Non-rebreather, right? You can justify it super easy. But if I tell you normal is 94 to 96% and they're at 92, what would you choose? Nasal cannula, right? That's why we've moved those numbers down, is it decreases your want to go, well, I need to raise it 8%. So you apply that same rule. If I say 94 and they're at 88, you would use a non-rebreather to move them up, right? BVM is only for inadequate, right? You can have a person with 85% saturations be conscious and alert, right? Breathe a little bit fast. You would put them on non-rebreather and try to bring them up. Now, if they're 85% and unconscious or altered or something like that, you're going to bag them. Make sense? Does this slide make sense to everybody? Okay? Oxygen is a drug. You need to know everything there is to know about it. Okay? So here's where it can get false readings. Shock, hypothermia. I'm going to go through and then tell you why. Carbon monoxide, poisoning, specifically cyanide, excess movement, nail polish, and anemia. Okay? So shock is always a problem, okay, because they're losing blood volume, right? This takes one hemoglobin and shines a UV light through it and tells you it is 96% oxygen. Does that make sense? One hemoglobin. So if your body only had one hemoglobin, would you still be suffering from hypoxia? Absolutely, right? So if you're dumping blood somewhere, and let's say you only have 1 liter of circulating blood volume, you'd be dead, but it would still tell you you were at 96% oxygen, right? Why hypothermia? And you can put cold extremities, because that's also there's that. Why does that mess with it? Yeah, so it actually shunts it away from your extremities, so it will give you a false low, right? So cold extremity is not very good. Carbon monoxide has the same transparency to UV light as oxygen. So it looks at that, and carbon monoxide binds to your hemoglobin twice as good as oxygen, right? So I always use like a catcher's mitt analogy. Your hemoglobin is a catcher's mitt, right? Oxygen is the baseball sitting in the glove, okay? The downfall is a softball, carbon monoxide, will stick to your glove twice as good as that baseball, right? So if there's a softball there, your baseball can't go in your glove, right? It'll just bounce off and fall to the ground. That's the problem with carbon monoxide poisoning. Does that make sense? Is your hemoglobin already has 100% CO, which doesn't allow oxygen attached to it, but it still reads it as if it was oxygen. Okay? We talk about poisonings here in a couple of weeks. There's actually a new device that's out that's an SpO2 monitor that reads CO as well as oxygen. So it can actually tell us if it's CO or if it's oxygen. Okay? Cyanide's the same way, right? Has the same transparency. Excessive movement, they're shaking their hands, that UV light's always moving, right? Doesn't allow it to work very good. Nail polish is an issue because the UV light won't go through the paint, right? Therefore, it gives you false readings. Chronic smokers are the other ones, right? All that buildup on their fingers doesn't allow the UV light to work like it's supposed to. Okay? Go ahead.
What if someone has nails like this? How do you, like, with nail polish?
You can do earlobes, right? Because it's the same idea, right? You have oxygen cells in your ears. So you can take that same device and just clip it on there, like push on the earlobe, and it'll give you an accurate reading, right? Toes, but if they got toenail polish, you have the same problem. Always treat your patient, not your equipment. Does that make sense? If it's telling you it's 65%, they're warm, pink, and dry, and conscious and alert, it's not. They're not at 65%, right? If it's 65%, they should be cyanotic and unconscious, right? If it's giving you 100%, they're unconscious and cyanotic, it's wrong, okay? If you follow your equipment, it will burn you every single time, okay? Remember, treat your patient, not your equipment, okay? Anemia is the same way. This is, lack of red blood cells let's say just for the generalization of that. So you might have good oxygenation on that one hemoglobin, but if you're lacking red blood cells, you'll be suffering from hypoxia, but your SpO2 will still give you a normal reading, right? Same idea as shock. So glucose, right? Blood glucose meters. Okay, this measures the quantity of glucose in the bloodstream. Okay, now we used to tell you you only do this on diabetics. This is really, really good to do on almost all of your patients. Okay, as long as your protocols allow it, do it on every single patient. We write this usually as BGL, blood glucose level. So we say 35 BGL, or BGL is 35, and it's actually MDL, I think, right? Something deciliter. Yeah, milligrams per deciliter. I think it's is it MMGL or MGL? I think it's just, or DL, right? So MDL. That was a real long conversation. Thanks for your help on that one. Man, I feel like that was a really long process. So most of our glucometers have these together, right? We got the strips. We got the glucometer itself, we got alcohol preps, we got Lancets, or the finger pokers, and then there's Band-Aids, right? We usually all keep it in one. Now, patients have them, or we can have them in our ambulance. It just depends on your protocols, okay? It's real easy. You take a finger, try to use a non-dominant finger, right? Pointer fingers and thumbs are not the best fingers because they're always using them, and poke them might cause some pain or whatever, some crybaby thing. So I always pick on like a pinky or a ring finger or the middle finger, you basically fill the finger with blood, right? So you kind of push blood up into that finger and then kind of just clamp it off so it turns nice, good red color, right? Now, you're going to take that alcohol prep, and on the side, try not to poke them in the pad of the finger. On the side, take the alcohol prep and clean it, okay? Then your partner should be taking out one of these lancets, or your strip, sorry, and put it in the machine. Most of these machines, you put the test strip in, it turns on automatically, okay? These have to be calibrated to this lot number of strips. So that's something really, really good to do before you go on a call, right? When you're checking out your rig, make sure your glucometer is set to this set of strips. Inside these, we'll have a calibrator strip that's meant to calibrate them, and then you're good for that entire pack of strips, okay? So you put one of these strips in. Make sure the end that's supposed to have blood on it is not the end that you put inside of that glucometer. I'll tell you a horror story here in just a second, okay? So put the strip in, this turns on. Usually it shows up with a picture of a strip and a drop of blood, something that tells you it's good to go, okay? Your finger's squeezed, you've cleaned it. Now, there's a million different types of lancets. These ones, you pull the blue piece out, push this end against the skin, and then push this end, and it spring loads a needle, just pokes you in the finger. There's a million different types of these, right? Some of them, when you push, they automatically fire. I've even seen ones that are just a little itty-bitty needle that you just manually poke them with, okay? All different types. So you poke them for a drop of blood, right? Your textbook will tell you to waste the first drop of blood, okay? The downfall is some of your chronic diabetics that have been poked a billion times in their fingers, you won't get a second drop, right? So just use that initial drop of blood in most of your chronic diabetics, okay? If they're bleeding real good, wipe that blood away and then get yourself another drop, okay? Drop of blood on that test strip, which then this should all of a sudden count down. Usually it counts down from like 5. 5, 4, 3, 2, 1, and then the number pops up, and that's your glucose. Make sense? Wipe their finger clean of blood, take that Band-Aid, put the Band-Aid on their finger, and you're good to go. Blair? You should. Most of these, because once they spring, they're done, right? They don't spring again. Make sense? All this stuff is thrown away. I've seen it done, right? But usually I like to poke them in their finger. Usually I'm not like, hey, since you're bleeding out of your forehead, you mind if I need it? Yeah, I've seen it on cardiac arrest, right, where they're, traumatic cardiac arrest, and the guy's just like on the pool of blood on the ground. I guess it works, right? Most of us, if you're starting an IV, we can take it off of the needle catheter, right? Then we don't have to poke them in the finger. If we get blood in a catheter, we can check it off that needle stick. We talk about medications, I'll pick on one of you, and I'll stab you with a needle and show you how IVs work, and I'll show you how to take a glucose off the needle, okay? So that's pretty straightforward. The horror story I have is, I don't know what EMT class, thank God it wasn't mine, this student went to, but they were told to put blood on the strip and then put the bloody end inside the glucometer, right? Guess what? That entire glucometer, that's a $100 piece of equipment, gone, right? Because now it's contaminated with someone else's nasty blood. In some protocols, believe it or not, they still require that you call medical direction and ask if you can take a glucose. Be thankful that Washington State is not one of those. Yeah. Idaho, I'm pretty sure, is still a mother, please, may I take a glucose state. California is a mother, may I state for everything, including breathing. Right? You got to like call to go on calls. Hey, doc, do you mind if I actually go save someone's life? California is like one of the strictest states to work in EMS. Believe it or not, Washington is one of the lax states. You can do whatever you want in Washington, right? It's like forgiveness, not permission, and half the stuff that we do, which is nice. Yeah, we're just like, yeah, whatever, right? Normal, the bottom end, 60 to 80. Okay, the high end, 120 or 140. Now, when we talk about diabetics here in a little bit, I mean weeks. Maybe it's less than that, I don't know. They're going to tell you that anything above 160 is like concerning. I go on chronic diabetics who normal glucose run 200, 340, 350, 360. Right? The textbook wants a one-size-fit-all for everything. Right? Humans aren't one-size-fit-all. So you get a blood glucose of 360, and you say, is that normal? They say yes, it's a little less concerning. Right? you say, what is your normal, diabetics will know their normal glucose, right? What is your normal glucose? It runs about 140. You come back and it says 360, that's concerning, right? Now, these monitors, every once in a while will come with what it'll say error. Yes, ma'am?
Back on the other one, the,
This one?
yeah, DL, and the
This is deciliter, milligrams per deciliter. So Jordan was wrong. It's actually mg/dl. Okay, I was wrong too. Okay, you happy? Make you look like an idiot in front of all my friends. All right, so, yeah, true story. You're drinking out of my damn coffee cup. So this will come up with error, right? ERR most times. First thing to check is batteries. Usually error is a battery problem. Okay, so if it's got spare batteries, great. Use someone else's glucometer, something. Every once in a while, if it's less than 15, the glucose, it'll just say low, right? If it's over 700, it will just say high, right? Most of these factory settings won't allow it over 700 or less than 15. If it says low, you got problems. If it says high, you got problems, right? My one horror story, had a guy that kept popping his error, right? And I was like, God, this thing, and he was a car crash that drove home on his own. This big, long story. He's been sick for like a week. He's got a temperature, all this crap. And so we're trying to figure out what's wrong with him. And so we just transport him. The hospital was like, did you check your glucose? And I was like, we tried 4 times. And we kept getting error. I think our glucometer's battery is low. And the nurse, like, ran up one side and down the other of me and told me how worthless I was. So we got back to the dorm, and she called the dorm and said, you want to know what his glucose was? I was like, what? She goes, 1,270. Mike, you can't even put that many numbers on the screen of my glucometer. What do you want from me? And she's like, well, you need to learn how to take a glucose. Okay, ma'am, have a wonderful day. Click. Right? It's never going to read that high. 700, it's going to read high. It read so high, it popped up as an error. Right? The glucometer's like, meh. Right? That's how you know your blood sugar's slightly high enough. Yeah. And he was septic. That guy's probably going to die within probably hours had he not gone to the hospital. Right? Not my problem.
My grandma was in a diabetic coma with glucose like 1,700.
Yeah, it's brutal. Yeah, sepsis will mess with your body real bad. Yeah, sickness and diabetics don't go very well. Awesome. Good, great story. Glad for your grandma. All right, so on your supraglottic airway skill sheet, some of you picked up on the fact that one of the very last things it talks about is confirmation of tube placement, right? How many of you saw that? It's got 4 different terms: capnography, capnemetry, EDD, and colorimetric device. Okay? When you drop your king air, you have to confirm one mechanical way and one electronic way. Okay? Mechanical way is chest rise and fall and lung sounds. Electronic way is one of these 4 things. Okay? Capnography we talked about, right? Which is end-tidal CO2 or waveform. Does that make sense? You can use it to confirm if you're getting CO2 out of that tube, you're where it needs to be. Okay? Capnemetry was initially, these two terms are used synonymously. They're really different. We don't think they are. One is just a measurement one time, and capnography is the actual continuous measurement. Does that make sense? I don't care what term you use, but these are, for this case, these are the same thing. Okay? EDD is what's called an esophageal detection device. Why it's on that skill sheet, we're really not sure, because this doesn't work with king airs and combi tubes. Okay? It's a bulb, like you think of like a turkey baster, and they cut the end off of it, and it's just the bulb piece. What it's meant to do on an ET tube, this works great. You put it on the end of the bulb, and you squeeze it. Okay? Your esophagus is flexible, right, because it's soft tissue. Your trachea is rigid because of rings. You squeeze that and let go. If it pops back open, it's the trachea, right, because the pressure should draw the walls in and make that bulb stay closed. Does that make sense? The esophagus, that bulb you'd squeeze it and let go, and it would stay compressed because that pressure causes the esophagus wall to pull against the end of that tube. So it would tell you if you're in the esophagus or if you're in the trachea. Okay? The colorimetric device is a block, and this is only a one-time use thing. This is the one that we usually have on ambulances because of the cheapest version, right? It's a block that goes on, and when we mess with skills next time, I'll show you what it looks like. One end goes onto the tube, and it has a port for your bag, and it's got a carbon piece of paper on it. When you bag and let go, that carbon piece of paper starts out, I think, as like a real yellowy color, and it should turn gold, right? If you squeeze again, it should turn purple. Should it go like purple, gold, purple, gold, purple, gold? After a couple, that carbon piece of paper has been saturated with oxygen, and it will go just purple, right? But initially, how do you remember this is gold is good, right? Initially, that carbon piece of paper on exhale, right, or as you let go of that bag, should turn gold. Make sense? Because that's that CO2 causing that carbon piece of paper to change colors. Make sense? So gold is good in that circumstance. So from now on, when you confirm that tube placement, you drop that king, or you hang on to it, you bag, your evaluator listens to lung sounds, and you say, you get lung sounds, they say yes. You say, I'm now going to confirm, and you can pick one of these terms. Okay? I would stay away from this term. People botch this one every single time. Okay? You can say end-tidal CO2. You can say waveform. You can say colorimetric device, whatever you want to say. But know the word. Pronounce it like it's supposed to be so you don't look like a moron. Right? Colorimetric's a pretty easy word. I'm a big fan of EtCO2. I'm going to use EtCO2 and confirm my tube is in the right place. Boom, you're done. Make sense? That's easy. It's over. No, that was the small one. All right, hang on a second here.